Hi everybody, this is Lisa and I'm back with chapter 3, part 3. And I did fib to you just a little bit at the end of the last video. I told you we were finished with the guiding principles and we're not. So we're going to pick up in the middle of be discreet and continue to talk about the parts of being discreet in addition to HIPAA. One of the things that we need to be extremely cognizant of is what we say about other people and other providers. We do not want to say bad, nasty things because that would be considered defamation of character. So what we have to do is be very, very careful. If we say something about a practitioner or someone, it is considered slander. If we write something in an email, in a text, in a letter, or whatever it may be, that's considered libel. So again, slander is oral, libel is written. I just want to caution you about writing things on Facebook and through emails and texts. Those can be traced, and you may think you've deleted it, and there are ways for those things to be retrieved. So please be very careful what you write. If you don't want somebody to know what's written, then do not put it on a piece of paper or on a computer screen. We've actually had situations where we have had to pull all emails about a student or faculty member because of things that were said. Our IT department gets involved, and you just don't want to have to go through those things. So if you don't want to know, or you don't want somebody to know what you've said, then don't put it in writing because it will come back to haunt you. All right, so again, talking a little bit more about discreet patient privacy. Make sure when you're working with patients that you close the door and draw the curtain. If you walk into a room and the curtain is drawn or the door is shut, we knock and we ask if it's okay to come in. Let's say it's 5 o'clock in the morning and you need to draw some blood. You need to knock and make sure you get a confirmation because you may not realize what you're walking into. So it's really important that you honor that privacy and make sure you're giving them time to either get dressed, wake up, whatever it may be, behind that door or that curtain. We want to make sure that we drape our patients appropriately. We give them a sheet, a gown. This is my pet peeve. Do not give someone who is very small or very large a gown that they're either going to be able to wrap around themselves 3 times or not be able to get up over their arms. Look at the patient, look at the gown size, and make sure it's appropriately sized. I hate when they hand me a little person gown because I know it's not going around me. So please be very careful with that. Again, we know not to discuss patients in public areas, and we know to discuss patient issues only with other people that are authorized to know the information. There are a few issues that we do need to talk about, and that is when it comes to public safety and talking about contagious disease. This should be hitting home very, very close to us right now because of this coronavirus. One of the things that we have to report to the health department. But we're talking about things that may be a little bit more serious, like HIV. Let's say our patient has been diagnosed with HIV and they come in and they say, I don't want my wife to know. The patient has the right to ask that, and we must keep that information confidential. We may not think it's right because we think the wife has the right to know the information, but it doesn't matter. The patient has asked us to keep it confidential, so we do. On the other end of the spectrum, there are times that we have to break confidentiality. And that is if we think a patient is going to harm themselves or harm someone else. So if a patient says to us they're going to kill themselves or they're going to take all their medications, and we truly know that they are serious, then we are allowed to breach confidentiality so we can find help for the patient and make sure that they don't do anything that would be detrimental to themselves or someone else. The seventh area is keeping promises, and this is important to remember. When our patients come in, the patient has a contract with a physician, and they sign that contract on their first visit, and that's going to be on your patient information sheet. So when you go into the doctor for your first visit, you have to sign all that information. You have to put your name, telephone number, insurance number, all that demographic information, where you work. And then at the very bottom, there's usually a little box that says, we have the right to bill your insurance, and all these other little things. When you sign that document, you have signed the contract with the physician that he is or she is going to provide your care, and that you are going to keep up your end of the bargain and show up for your appointments, take your medication, do what you need to do to keep yourself healthy. So there's three parts to a contract. The first part is an offer. And when we talk about an offer, that is when there's an action that starts the process of forming a contract. So in most cases with us, it's the patient calling and saying, are you taking new patients? They come in for their first appointment. They read through the documents because we give them 5,000. Okay, maybe not 5,000, but at least 3 or 4. They have to read our privacy policies. They have to sign off for HIPAA. There's a number of things. When they do that, they're looking at that information. That's what we consider an offer. Acceptance means that both parties accept the terms. So the doctor accepts them as a patient. They're going to provide good quality care, and the patient steps up to the plate and says, I'm going to take care of myself and do what you ask me to do. Consideration is something of value that has to be exchanged. And in the case of healthcare, it's money and insurance. So we have a copay. We pay that copay. If we don't have a copay, our insurance company pays for the visit, and that's that consideration. It really isn't too difficult, but when you have to think about those things as we break that down. Just like with consent, there's different types of contracts. So when we look at expressed contracts, it's when it's either written or oral, and there are specific terms and conditions on that everybody agrees to. So I want you to think about when you hire a contractor to come into your house. You say, I want you to paint the walls, I want you to lay new flooring, and I want you to put a new bathroom in. You are very specific, as well as the contractor, on what's expected. Because if something happens, you are going to use that document, that expressed contract, to use in a court of law to say, they were supposed to paint my walls, but they never did it. So I shouldn't have to pay for that part of their services. An implied contract is very different. This is kind of where you walk in and you say, I've got a toothache. Is the doctor accepting new patients? Yes, it is. We go in, we allow the doctor to treat us. It's very much like implied consent. We go in, we open our mouth. It's like we are consenting by opening our mouth and letting the physician work on us. We also have to look at breach of contract. And that's when one of the two parties falls out or fails to carry out their part of the agreement. And this is really important to understand. The patient has a duty to take care of themselves, show up for appointments, pay their co-payments, pay off their bills, follow the doctor's orders. Because this is a contract with the patient. And if something happens to that patient, and the patient's family sues us, we have to be able to prove in a court of law that we have provided the services that we agreed to. On the same wave, the patient has to follow suit as well. They have to be able to pay their bill. They have to be able to pay and have the insurance pay their bills. They have to show up for appointments, and they have to follow the patient's plan of care. If they don't, and something happens to them, again, the family can sue, and there's nowhere in there that we have documented that the patient was not following the plan of care. They weren't showing up for appointments. That's why it's so important that we document all of these things. Because in healthcare, if we don't document, it didn't happen. So every time a patient is a no-show or a cancellation, we document that in the chart. So the patient can get out of the contract anytime by saying, I'm going to be moving. I need to, break this contract, and I'm going to go get a new physician in Baltimore, and I need you to send them my records. That's not really a breach of contract, but we are breaking that contract to move on. They have the right to do that. What we do not have the right to do as a physician or practitioner is just quit seeing a patient because they irritated us, they didn't show up, they didn't do what they were supposed to do. We can excuse them from the practice, but there is a very specific way we have to do this. The law requires us to send a letter to the patient and explain to them why you are no longer going to be their care provider. They didn't show up for the appointments on this date, and this date, that they're not taking their medication, whatever the reason may be, that they are not going to continue the care is going to be outlined in that letter. That letter is going to be mailed, return receipt requested, registered, certified, so we know that the patient received that letter. We keep copies of that in the patient's chart. Once we know that that patient has that information, the letter is going to state in 30 days of you receiving this letter, you will no longer be considered a patient in this practice. You have 30 days to get your records transferred to a new physician. After the 30 days, we then can mark them as no longer a patient. If we don't go through this process, it's considered abandonment. And abandonment is actually a terrible thing because you can actually be arrested and fined for leaving your patient without medical care. So it's truly important that you know that. So you document everything that you need to make sure we have all the information we need to make informed decisions about our patients. Damages are money to compensate for injury or loss. It's not as easy as that. There's a lot of different parts and pieces to proving somebody did something and that the cause was what the physician did. So I'm going to give you an example. This is a true story. I worked in an OBGYN office. The patient came in for hysterectomy, and the doctor told her in writing with post-op instructions they were not to lift anything heavy for 6 weeks. There were very set directions. Well, about a week in after her surgery, I got a call from this patient, and she said, "Oh my gosh, I think I did something wrong. My incision is opening." She said, "I was helping my husband getting a motorcycle off of the back of the truck, and I felt it pop, and I don't know what to do." I said, "Well, I'll tell you what we're going to do. We're going to get you in to see the doctor as soon as possible." I found an appointment that day in about an hour put her in that appointment and documented every single thing the patient said. When she came in to see the doctor, she had a very different story. She said, I really don't know how this happened, but, the stitches just didn't hold. There's a huge difference there. In the first scenario that she told me, the fault was on her. She did something she was not supposed to do. And because of that, she can't sue the physician because it was her negligence that caused the stitches to open. She probably thought about that and then made the decision, well, I'm not going to say that because I don't want to get in trouble. So she came in and said, no, the stitches came out. They must not have been done correctly. That's a very different story, because if that was true, the patient would have the ability to sue that doctor. And if there were damages, that the physician would have to pay for that. So it's really important that if you're on the end of the phone that's taking information, please document the important things people are saying. An agent is someone who represents another person when they're making a contract. Excuse me. This is, again, a very important piece, especially for the medical assistants out there. We work under the auspices of the physician's or provider's license. We are not licensed in any state. This is true for other assistants out there as well. So if a doctor asks us to do something and we do it and something happens, they're going to sue the doctor, not us, because we're working under their license. And that's called respondeat superior. And this is in your textbook on page 81. It means let the master answer. So let's say we're working in an office and we go in and the doctor tells us to give medication and we pull the wrong medication and give it to the patient. We made the error, but the person that's going to get sued is probably going to be the physician. Not probably, it will be the physician. They may try to sue the MA, but what they're going to go for is the deep pockets. God knows we don't have a lot of money, but they know the physicians carry millions of dollars worth of liability insurance. And it's really important for them to keep that up, because that's what's going to happen. They're going to say, you gave me the wrong med. They were incompetent. They were acting as your agent. So therefore, I'm going to sue you because you have people working for you that didn't know what to do. Kind of scary, but it's true. Okay. We just talked about the respondeat superior. It is a legal doctrine, again, that holds the employer responsible for the actions of the people working underneath their license. So let's look at another question. Which of the following is an example of a breach of contract? Is it A, a patient refuses to pay for treatment because he's not happy with the result? B, a physician refuses to perform a treatment based on information from lab tests? Or C, a physical therapist cancels future appointments because the patient will not do the prescribed exercises? So take a minute and look at that. And hopefully you answered A. A patient refuses to pay for treatment because they're not happy with the results. Whether they like it or not, the care they receive, they still have to pay for services. And the last area of our guiding principles is going to be do no harm. And again, this is the whole premise behind the Hippocratic Oath. So the essential responsibility of all healthcare professionals is to take care of our patients and do no harm. So there's a few terms that you're going to need to know. The first one is negligence. And negligence means that you did not act in a reasonable standard of care. So when we look at that, it's important to think about that. So, did you do what you were supposed to do? So let's say the doctor told you that you needed to do a breathing treatment on a patient in exam room 2. Well, you look in and you don't think that patient's that short of breath. So you just go on your way, you document that you did the treatment and patient's discharged and they go home and they have an asthma attack. And the doctor said, how can that be? You gave them a breathing treatment. And you documented that you did. That's negligent. You did not meet a reasonable standard of care. You did not do what the physician asked you to do, and you documented something that you didn't do and probably charged for it as well. That's a major problem. Professional negligence, again, we'll see lawsuits surrounding professional negligence. This is where our scope of practice comes in so much. You should only be doing the duties that you have been trained to do. So I gave this example earlier. If the doctor's running late and they need to do a minor office surgery and they say, hey, go in and do this Mohs surgery, I'll be in to finish it up. We can't do that. We are not a physician or a practitioner that is trained to do that. And so we are working well out of our scope of practice, and that would be professional negligence. So please know your scope of practice. Please know what you can do and what you cannot do in your agency or in your office. The interesting thing about this is they've actually done studies with this. They have seen doctors who are excellent physicians, and they have more lawsuits than doctors that are absolutely horrible, but have a wonderful bedside manner and treat their patients very well, which is interesting. So we have a surgeon whose skill is excellent, but he doesn't know how to communicate well, and gets sued more than a doctor that has more mistakes, but yet because of his relationship with his patients, he does not or she does not get sued. I just think that's amazing when we look at that. The moral to that story is we treat all of our patients with kindness and respect, communicate with them, listen, and you're going to have a good relationship with your patients. So even if something may go amiss, they're still going to hold you in high esteem and you may not get sued. So true or false? Poor communication between the patient and the healthcare professional is a major cause of malpractice lawsuits. And hopefully you said that is true. Poor communication and patient anger are some of the major contributors to malpractice lawsuits. I want to talk a little bit about the Good Samaritan law. That is what protects us if we give care to people in emergency situations. You need to be very aware that Good Samaritan laws change from state to state, and you need to be aware of what they are. Because if you have a scope of practice and you are in a situation with that you have to provide care, you need to know if you're going to be held to a higher standard than somebody else who has no training that walks in on the street, off the street. Okay? Now, you know, one thing is when we are on the clock, we have to provide every bit of care. So let's say our patient's walking down the hall, they fall over, they have a heart attack. Because we're on the clock, we have to provide CPR. We're going to do CPR, we're going to do rescue breathing, and we're going to try to stabilize them until EMS can get there. If we're out to lunch and we've clocked out, and you're sitting at the table and somebody next to you falls over, dead from a heart attack, as long as your state doesn't say you have to do something, you don't have to do it. You can act like you're a hairdresser or you're, you work at Lowe's. You do not have to be a healthcare professional. So it's important to know what those Good Samaritan laws are in your state and what standard you're going to be held to. The Patient's Bill of Rights. This is from the American Hospital Association, and it talks about things. Oh, there's my clock. Hang on. Sorry, I didn't think you wanted to hear that rendition of the song. So the Patient Bill of Rights, it's actually now known as the Patient Care Partnership. You can actually click the link to be taken to that. What it states is a lot of times this is mostly geared for acute care, to hospitals. But if you look at this, you can actually adapt these very well to outpatient care as well. So what the Patient Care Partnership says, or the Patient's Bill of Rights, is that a patient can expect high quality care, a clean, safe environment, involvement in your care, protection of your privacy, help when leaving the hospital or maybe the office, and help with your billing claims. So while this is hospital-based, we can do every one of those things in an outpatient office. When it says when leaving the hospital, I want you to think about that. We have people that are patient navigators. Our patient comes in, or case workers that work with patients who need help with electric or gas being turned on or off, with food, with child care, with specialists. We help them get those connections just like they do at the hospital when people are discharged. So, hint, 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 this is probably something you may want to write down on a piece of paper because you're going to need to know those and be able to discuss those. So when we look at the Affordable Care Act, excuse me, there was a lot of things that weren't great about the Affordable Care Act, but there were some things that were very good about the Affordable Care Act. And on page 83 in your text, it talks a little bit about some of the things that were included in the Affordable Care Act. Again, there's no lifetime dollar limit for coverage of defined essential benefits. This is really important because in the past, there was a limit. And once you got to that limit, the insurance company didn't pay anymore. And so people who had chronic illness, they were finding out that they had to spend down all of their assets to get on Medicaid because their insurance company wasn't going to pay any more of their bills. Denial of, because of pre-existing condition. Again, this is huge. People with chronic diseases were being turned away from getting health coverage in new employment. And that is something that was stopped due to the Affordable Care Act. Patients or young people can stay on their parents' insurance until the age of 26. That is a great thing because, believe me, it's expensive. So as long as you can stay on your parents' insurance, it's nice while you're going through school and getting your feet set, or I can't think of what I want to say, but you're getting yourself settled. It's nice to have somebody else paying your insurance. That certain preventative health screenings are not extra charges, and 30 days notice of your health insurance being canceled. Okay. The other thing with that is that they talk a little bit about specialized patient rights, and that's when we go into mental health and hospice. Mental health is a totally different ball of wax. Confidentiality is at a much higher standard, and we have to be careful with that. And we're seeing a much higher incidence, or we're having people talk more about their mental health illnesses, and we're seeing much more in our population. When you look around Cumberland and many areas, we just don't have enough mental health services to provide quality service for our community. Hospice, again, very much like the patient care partnership, you need to be treated with respect. For hospice, this is palliative care, and that means it's end-of-life care. And what that is we're going to make them comfortable. We're not going to do any heroic life-saving measures. We're going to keep them comfortable with medication. Hopefully, if they want to stay home, we'll provide nursing care to let them stay home and be able to die in a dignified manner. They are allowed to refuse care or treatment, and they can choose their attending physician as well. Handling ethical dilemmas. This is a very important piece as we look at all of, when we talk about all these ethical issues. So, when we talk about ethical dilemmas, we have to make sure that the priority is the well-being of our patients. That's the most important thing that we need to make sure of. When we look at this, we need to look at accepting responsibility for making difficult decisions. It's part of something that we do every single day as healthcare workers. Take this situation now with the coronavirus. I'm sure you've noticed on our Brightspace, on Facebook, and those type things that they're out there working. They're not allowed to be sheltering in place. We have to make very difficult decisions every single day. And so this is something that you just get used to. You determine, you have a strong ethical point of view, and we just deal with things day by day as they come. The one thing that you do need to do is you need to report illegal behavior. If you are a licensed person, my respiratory license requires me to report someone. If I know someone is doing something wrong or illegal as a respiratory therapist, if I don't report them, they can actually take my license away from me as well as the person that is doing the illegal act. So it's very important that we keep our ethical control, and we make sure that we surround ourselves with people that do the right thing, that work, don't take shortcuts, all of those wonderful things. There's a number of different resources that you can use, and these are organizations that are faced with very difficult decisions on a regular basis. It's interesting if you want to go and look at some of these sites. It's the American Medical Association Council on Ethics and Judicial Affairs. The ethics committees that we talked about at different healthcare facilities. It's very interesting to sit on that and listen to what people say. Clergy and counselors are always working with people with ethical issues. And we have lawyers and risk management specialists as well. That is the end of chapter 3. So, if you have any questions, please feel free to contact me. And Good luck.